My name is Anthony Sanchez. My portfolio project will be examining the respiratory system. We will be looking at the anatomical and physiological aspects as well as addressing medical issues associated with respiratory organs. Lastly, we will examine the medical procedures involving lung transplants in hopes of treating cystic fibrosis. To begin, we will look at the overview of the respiratory system. There are three major parts of the respiratory system. First, the airway. Second, the lungs. And last, the muscles of respiration. The airway, which includes the nose, mouth, pharynx, larynx, trachea, bronchi, and bronchioles, carries air between the lungs and the body's external. The lungs push oxygen into the body and carbon dioxide out of the body. The muscles utilized are the diaphragm and the intercostal muscles. They work together to act as a pump, pushing air into and out of the lungs during respiration. When looking more closely into the anatomical parts of the respiratory system, we realize that every part of the body has a function and a purpose. Beginning with the nasal concha and nasal mucosa, the function is to filter, heat, and moisten the air during both inhalation and exhalation. Next is the pharynx. The pharynx is a passageway connecting the nasal cavity to the larynx and oral cavity to the esophagus. It is subdivided into three different sections called the nasopharynx, the oropharynx, and the laryngopharynx. It houses the tonsils, which help protect against pathogens entering the mouth. Lastly, its main function is for the passage of air and food. Next, moving down, we come in contact with the larynx. The larynx connects the pharynx to the trachea. It is made of cartilage and dense connective tissue, which houses the vocal cords. Its main function is to prevent food from entering the lower respiratory tract and voice production. Next is the trachea. It is a flexible tube running from the larynx and divided inferiorly into two main bronchi. Its purpose is for air passageway. It is to clean, warm, and moisture incoming air. Next is an overview of the external and cellular respiration within the lungs. Cellular respiration refers to the reaction of oxygen with organic molecules to produce carbon dioxide, water, and energy in form of ATP. External respiration is a movement of gases between the environment and the body's cells. It can be subdivided into three processes. First, the exchange of air between the atmosphere and the lungs, known as ventilation or breathing. Next is inspiration, or the movement of air into the lungs, known as inhalation. Last is expiration, or the movement of air out of the lungs, known as exhalation. These are all the mechanics of breathing. The image below shows the exchange of carbon dioxide and oxygen between the lungs and the blood, traveling to the systemic capillaries, back to the lungs again, where the exchange of gases between the blood and cells take place. The trachea is a semi-flexible tube held open by 15 to 20 C-shaped cartilage rings. Within the lung, the smallest bronchi branch is to become a bronchioles. These are small collapsible passageways with smooth muscle. The diameter of the airways become progressively smaller from the trachea to the bronchioles, but as an individual airways get narrower, their numbers increase geometrically. As a result, the total cross-sectional area increases with each division of the airways. The alveoli are the site of gas exchange. These are clustered at the ends of the terminal bronchioles. They make up the bulk of lung tissue. Their primary function is to exchange gas between themselves and the blood. There are two types of epithelial cells found in the alveoli. The smaller but thicker is type 2 alveolar cells, which synthesize a chemical known as surfactant. This thin fluid lining of the alveoli help aid lungs as they expand during breathing. Type 2 cells also help minimize the amount of fluid present in the alveoli. The image below shows the branching of the airways starting from the larynx descending to the alveoli, as well as the structure of the lung lobule with bronchioli, the smooth muscle, the branch of the pulmonary artery, as well as the elastic fibers, lymphatic vessels, the alveoli, and the capillary beds. Below that is the alveoli structure, with the type 1 alveolar cell for gas exchange, the endothelial cells of capillary, the type 2 alveolar cells, the limited interstitial fluid, and the macrophages that ingest foreign material. The last image on the bottom right represents gas exchange between alveolar airspace and plasma. The larger type 1 alveolar cells occupy about 95% of the alveolar surface and are very thin so that gases can diffuse rapidly through them. In much of the exchange, a layer of basement membrane fuses the alveolar epithelium to the capillary endothelium. The close association of the alveoli with the extensive network of capillaries demonstrates the link between the respiratory and cardiovascular system. Blood vessels fill between 90% and 80% of the space between the alveoli, forming an almost continuous sheet of blood in close contact with the air-filled alveoli. This is essential for rapid gas exchange. We will look at the ciliated respiratory epithelium. The ciliated respiratory epithelium is composed of goblet cells, cilia, and mucus, all to which help cilia move the mucus layer toward the pharynx, removing trapped pathogens and particulate matter. Lastly, we will be looking at lung volume and capacity. To begin, we will look at tidal volume. Tidal volume is a volume of air that moves during a single inspiration or expiration. The average tidal volume during quiet breathing is about 500 milliliters. Now, the additional volume you inspire above tidal volume represents your inspiratory reserve volume. This is about 300 milliliters, a six-fold increase over the normal tidal volume. Next is expiratory reserve volume. This is the amount of air forcefully exhaled after the end of normal expiration. The average expiratory reserve volume is 1100 milliliters. The fourth volume that cannot be measured indirectly is residual volume. The volume of air in the respiratory system after maximal exhalation is about 1200 millimeters. Most of this residual volume exists because the lungs are held stretched against the ribs by pleural fluid. Now, looking at lung capacities, the sum of two or more volumes is considered a capacity. First, the vital capacity is the sum of the inspiratory reserve volume, expiratory reserve volume, and tidal volume. Vital capacity represents the maximum amount of air that can be voluntarily moved into or out of the respiratory system with one breath. The way you find total lung capacity is vital capacity plus the residual volume. Other capacities of importance in pulmonary medicine include inspiratory capacity, which is tidal volume plus inspiratory reserve volume, and functional residual capacity, which is expiratory reserve volume plus residual volume. This concludes the anatomical and physiological aspects of the respiratory system. Next, we'll be looking at the medical issues regarding the respiratory system. The medical issues that will be addressed will be emphysema, asthma, and cystic fibrosis. Beginning with emphysema, it is characterized by a loss of elastin, which helps the alveoli recoil during expiration. Elastin is destroyed by elastase, an enzyme released by alveolar macrophages, which must work overtime in smokers to rid the lungs of irritants. People with emphysema have more difficulty exhaling than inhaling. Their alveoli have lost their elastic recoil, which makes expiration, normally a passive process, require a conscious effort. Smoking is the leading cause of emphysema. The inner walls of the air sacs weaken and eventually rupture, creating one larger air space instead of many small ones. This reduces the surface area of lungs and in turn, the amount of oxygen that reaches your bloodstream. Asthma is a chronic lung disease that inflames and narrows the airways. It causes recurring periods of wheezing, coughing, and shortness of breath. Today, over 25 million people are known to have asthma. The severity of an asthma attack can escalate rapidly, so it is important to treat symptoms immediately. Without an inhaler or bronchodilator, breathing will become more difficult and labored. If you are unable to breathe, less oxygen will be in the blood, and without aggressive treatment, asthma may lead to death. Cystic fibrosis is a life-threatening disorder that causes severe damage to the lungs and digestive system. An inherited condition, it affects the cells that produce mucus, sweat, and digestive juices. In cystic fibrosis, a defective gene causes the secretions to become thick and sticky. Instead of acting as a lubricant, the secretions plug up tubes, ducts, and passageways, especially in the lungs and pancreas. Depending on the severity of the disease, symptoms may worsen or improve as time passes. Respiratory signs and symptoms include a persistent cough that produces thick mucus, wheezing, loss of breath, a decreased ability in exercising, repeated lung infections, and inflamed nasal passages. In cystic fibrosis, the cause of the disease is a defect or a mutation in the gene that regulates the movement of salt in and out of cells. This results in thick mucus in the respiratory and digestive as well as reproductive systems. The affected gene is inherited from children's parents, which is recessive. In a normal, healthy lung cell, the CFTR protein allows chloride ions to pass through freely. While with a door-jamming mutation, the CFTR protein is closed, causing a buildup of chlorine ions within the cell. The chloride ions result in the sticky mucus buildup which flattens the cilia. This disables this function at the cell's surface. With the common delta F508 mutation, the CFTR protein is made, but is unable to reach the surface. This results in having two issues, a problem with the location and function. Lung transplantation is a surgical procedure in which a patient's diseased lungs are replaced by lungs which come from a donor. Lung transplant is a therapeutic measure of last resort for patients with end-stage lung disease who have exhausted all other available treatments. Certain pre-existing conditions may make a person a poor candidate for lung transplantation. Things like concurrent chronic illness, current infections, recent cancer, or use of drug and alcohol may induce a transplant. Requirements for potential donors are health, matching lung size, age, and blood type. The type of lung transplant with cystic fibrosis is called a double lung transplant. Due to bacterial colonization commonly found within the patient, both lungs are needed to be replaced. The transplantation process starts after the donor's lungs are infected and the decision to transplant has been made. An incision is made from under the patient's armpit around the sternum and then back towards the other armpit. This is known as a clamshell incision. In this case of a sequential transplant, the recipient's blood vessels are tied off and cut at the corresponding bronchi. The new lung is then replaced and blood vessels reattached. To make sure the lung is satisfactory, they perform another bronchoscopy. When the surgeons are satisfied, surgery on the second lung will proceed. In 10% to 20% of double lung transplant, the patient is hooked up to a heart-lung machine, which pumps blood from the body and supplies fresh oxygen. Complications include post-transplant lymphoproliferative disorder, a type of lymphoma due to the immune suppressants and gastrointestinal inflammation. Transplant rejection is a primary concern both immediately after the surgery and continuing throughout the patient's life. Because the transplanted lungs come from another person, the recipient's immune system will see it as a foreign body. Transplant rejection is a serious condition and must be treated as soon as possible. Chronic rejection, meaning repeated bouts of rejection symptoms beyond the first year after transplant surgery, occurs in 50% of patients. For lung transplant, 83.6% survive after year 1. After 5 years, 53.4%. After 10 years, only 28.4% survive. The controversy behind the respiratory lung transplant procedure is due to its low efficacy rate, as well as its cost, and as well as its success in post-surgery.